Hi, my name's Dr. Howard Chertkow. I'm a neurologist in the Memory Disorders Clinic at Baycrest Hospital in Toronto, and I also direct the Clinical Trials Unit here at the Rutman Research Institute. I'm going to speak to you about clinical research on patients seen in the MINT memory clinics across Ontario. We hope this will inspire you to get involved in referring patients for clinical research. We're working with Linda Lee in setting up such a system. In this 15-minute talk, I'm going to review the advantages for everybody of referring patients seen in MINT memory clinics for clinical research. As background, I'm a professor in medicine and neurology at University of Toronto. Here are my commercial interests. Over the years, I've been involved in many clinical trials for pharma. I'm also supported by a research chair, funding from the CIHR, the Weston Foundation, and many partners of the CCNA, which I'll talk about briefly. First, what is good about MINT clinics? From my perspective, there are many benefits. The MINT clinics speed up the process of having patients with cognitive impairment evaluated, which is hugely important. It maintains the pair of patients with their family physicians. The care of patients remains with the family doctor, and referral to a specialist is decreased. And in fact, data shows that 9 out of 10 individuals with cognitive impairment can be well handled at the MINT level without necessitating referral to a specialty memory clinic. This fits in with provincial plans developed in Quebec and Ontario, whereby the family physician plays the key role in evaluation, diagnosis, and treatment of individuals with cognitive impairment and dementia. The MINT clinics appear efficient and workable, and as long as we institute rapid referral to specialists with a corridor when necessary, the system seems to be the best way to proceed. So MINT clinics are essential, effective. Can they lead to clinical research as well? The first question is how, and what we've discussed with Linda Lee is that when seen in the MINT clinic, each patient could be asked, are you interested in learning more about participating in clinical research? If the individual replies yes, then they and their families can be given a pamphlet, and this is being set up now, with a phone number to call or an email number to call, either locally or centrally, to connect the client or patient with clinical research across Ontario. The numbers and email supplied will connect with a research coordinator, and this may be either locally or a CCNA representative or Andre representative to give information about research going on currently at all of these locations, because currently there's clinical research on dementia going on in London, Hamilton, Waterloo, many hospitals and institutes in Toronto, Peterborough, Ottawa, and even Thunder Bay. This is a list of only some of the hospital centers currently involved in clinical research on dementia. Now, we don't expect individuals at the MINT clinic, physicians or their assistants, to know all of the clinical research going on because it will change year by year. So a system needs to be set up where all of these projects can be accessed with one phone call. What are the benefits? Well, from the researcher perspective, there are many important benefits. First, having MINT take an initiative in clinical research maintains a connection between researchers and the family physicians, and this is essential. It also brings about support from the family doctors. Without support and positive encouragement, your patients are far less likely to seek out clinical research. Most important, it will help us get the missing research subjects. What do I mean by that? Well, recruitment into dementia clinical trials is a major challenge. We need individuals with mild dementia, especially Alzheimer's disease, or mild cognitive impairment to enroll in therapy trials. As it is currently, complicated patients come through our specialist memory clinics, and the better patients, who are patients with simple Alzheimer's, simple MCI, they stay with their family practitioners, and they're no longer seen in specialty memory clinics. In addition, the waiting time to get into a specialty memory clinic can be more than a year. So by setting up a system where there's referral from the MINT clinics, we can see the appropriate research subjects quickly for research evaluation, see them, communicate back with you, the primary care provider, give them support, and offer the potential to be involved in cutting-edge therapies and evaluation. What about the benefits from the family physician's perspective? Well, currently, dementia is incurable, and we must change that. We must do more to help our patients in the future. Being involved in research offers hope for your patients. It gives them access to cutting-edge therapy, which, if effective and successful, will not be available in pharmacies for a good number of years. And this allows all physicians to support the important academic mission to advance the field towards better treatment and prevention of dementia. What about from the patient perspective? Clinical research is beneficial. It has been shown that individuals who are enrolled in clinical research have a better outcome than individuals who are not enrolled in clinical research. We follow them closely, we do blood tests, sometimes we find things that were not suspected or being investigated. In addition, involvement in clinical research gives your patients access to cutting-edge therapies not yet available in the pharmacy. It gives them hope. They're doing something, and they're doing everything they can to try to prevent and treat the dementia. In addition, the patients become part of the big picture. They are helping to find a cure, if not for themselves, then for the next generation. So these are all significant benefits for your patients by being involved in clinical research. We published in 2008 an important paper by David Hogan in CMAJ, which is still the best reference for diagnosis and treatment of dementia. And we list the things to do to assist patients with mild to moderate dementia after a diagnosis has been made. If you look on down the box here, the third element is referral to the Alzheimer's Society of Canada. And the fourth element on this page is providing information and advice about non-pharmacological and pharmacological treatment options and the availability of research studies. So offering research is one of the things that you should be doing after dementia is diagnosed. So what is going on in Ontario? Very briefly, what is going on can be summarized in these four headings. There's the CCNA, and here's the website, ONDRI, and there's the ONDRI website, C5R, which is the Consortium of Canadian Centres for Clinical Cognitive Research. This is the group that oversees clinical trials, particularly phase 3 clinical trials across Canada. And there's other clinical research based at university hospitals and academic memory clinics. So I can best give a survey of what's going on by explaining what's going on at my own Baycrest Rotman Clinical Trials Unit. First, we are a center for CCNA. This is the National Consortium of Researchers looking at prevention, treatment, and quality of life with 19 teams, and Compass ND, a clinical cohort, and Can Thumbs Up, a prevention cohort being set up currently across Canada. So CCNA is very present in Ontario and at the academic centers I previously listed. The CCNA's goals in its phase 2 are listed here: developing new treatment molecules, prevention strategies, and understanding subgroups and allowing earlier diagnosis. CCNA contains expertise from across Canada, but the largest group is within Ontario, where most of the dementia researchers are listed. Our clinical trials unit is a center for CCNA research, and it is set up at the Baycrest Health Sciences and the Rotman Research Institute. What we do is listed here, and this is the sort of research, clinical research carried out across Ontario. First, natural history studies of subgroups of Alzheimer's, cognitively impaired and unimpaired individuals, those with subjective complaints, and MCI, as well as dementia. So the Compass ND cohort study is the way we are studying these individuals across Canada, and ONDRI is also studying subgroups of individuals with dementia. Second, we are involved in a whole range of therapy trials: therapy of neurodegenerative diseases, non-pharmacological therapy such as cognitive stimulation and meditation, investigator-driven trials of different medications for treatment, prevention, and treatment of symptoms, pharmaceutical trials such as anti-amyloid trials and anti-tau. Those are via the involvement of pharmaceutical companies. Neuromodulation and other approaches to therapy. In my lab, we're looking at TDCS, transcranial direct current stimulation, which is electrical stimulation, and other investigators at U of T are carrying out such non-pharmacological trials. Third, we're involved in prevention studies, as I've mentioned. I'll come back to this. And fourth, there are non-therapy studies, cognitive and non-therapy studies geared to understand memory, and we work with all the 24 Rotman Research Institute scientists to carry these out at Baycrest. The general inclusion and exclusion criteria, basically we're looking for people with subjective or objective cognitive impairment under 90. They obviously have to consent and speak English or French in Canada, and be geographically accessible to the study site, willing to come in, and usually must have a study partner. And as you see, general exclusions are to exclude alcohol and drug abuse, other neurological diseases, stroke, and people who are simply too severe to participate. Most studies use MRI, so contraindications to MRI may be a contraindication to many studies, but not all. We carry out therapy studies, and as you know, most of the studies in the past 20 years have been geared towards immunotherapy to lower A-beta and get rid of amyloid. And over the past 20 years, most of these studies have been unsuccessful. However, in the past year, we've seen the partial success of aducanumab, which, as you see here, at 1 year, individuals on a high dose of aducanumab show decrease in the amyloid. This is amyloid PET. We can see the amyloid decreases after a year of therapy. And this has led to publications which claim to decrease the plaque and slow cognitive decline in Alzheimer's disease. So anti-amyloid studies may lead to new therapies. Anti-tau studies may also lead there. Within Compass ND, our national cohort, we are collecting a whole series of individuals with different forms of dementia, and we hope this will impact on our understanding of the diseases. We hope to see a future where we understand these dementias in terms of multiple pathologies, different mechanisms, and perhaps subgroups that require different treatments. For example, anti-inflammatory studies may be only leading to effective therapy in a subgroup of people and not everybody with Alzheimer's disease. We believe that there are multiple pathological processes involved in Alzheimer's disease, and by evaluating a large number of subjects, we will find a way to designate subtypes that may have specific therapies. Across Canada, if we look in basic science labs, there are scientists investigating alternative approaches, different therapeutic mechanisms, and again, we hope that by having support of the basic scientists, we will be able to carry out small-scale studies of new therapies in Canada, and these will lead to paths up the mountain to the top of the mountain, which is an effective therapy for Alzheimer's disease. In addition, we believe that delaying the onset of Alzheimer's disease will lower the prevalence. If we can delay only by 5 years, the prevalence of Alzheimer's will be decreased eventually by up to 50%. So within CCNA, we're developing optimal combination of therapies for dementia prevention over the next 10 years. And this is a main focus here within CCNA sites across Canada. We are currently assembling a Canadian cohort of participants without dementia, but with early MCI or SCI. And they will be put into a program where we support them with a brain health support program and then put them into randomized clinical trials over the next 2 to 5 years, trying different combinations of prevention therapy. At the same time, we have ongoing interventions which are non-pharmacological. These are 3 leading interventions going on at sites across Ontario, looking at language, music, aerobic and resistance training, cognitive stimulation, and other modalities to see if we can slow the progression of MCI going on to dementia. In addition, I mentioned non-therapy clinical research, development of new diagnostic approaches and studies of brain and cognition. These may seem at first light not to be so important to your patients, but in fact, these are the sort of studies which may lead to the most useful tools. This is the Montreal Cognitive Assessment that was developed in my memory clinic in Montreal and has led to a very useful screening tool which is used by most family physicians across Ontario. So this non-pharmacological, non-therapy sort of research may lead to the most useful aids that are having an impact on the care of patients across Ontario right today. And the MOCA is still available free. You just click on download the print version and click on assuming liability. It's still available free. So this is the sort of clinical research available for your patients at sites across Ontario: natural history studies, various sorts of therapy, prevention studies, and non-therapy studies. And by making a one-stop referral, we hope that we will be able to make the research available and beneficial to everyone involved. So we are asking you to ask your patients if they would like to be involved in clinical research. We're working out a form that will be given with contact numbers, so this will bring minimal additional time needs from the family physician. There will be no need to explain the studies or obtain a consent from your patients, simply giving them the form, and they will carry on from there, contacting the research coordinators and finding out about clinical research available in their area. So that's it. I hope I've made the case for referral of your patients. We hope to see a system working with Linda Lee and setting it up in the next months, whereby patients seen in your MINT clinics are referred for clinical research across Ontario, with little extra work for you and great benefit for all of us. Thank you very much.